I suppose what people fear is they look at the headlines and they think, oh, I'm already in pain, that operation is going to be put back. And can I guarantee that the optimistic promises are going to actually happen?
Well, it's part of our job to make sure that we deliver what we say we're going to deliver. I think for people that might be worried about what happens to them, if we look at the detail of the plan, what we're saying is that we are providing a lot more care for patients with a mental health problem, that we are increasing the support for people suffering with cancer. We are saying that we're going to have a 28-day diagnostic time for from time of referral to a diagnosis. That's something that people with cancer will feel, or with risk of cancer will feel very, I would guess, much happier about. It's nothing worse than waiting to know. And we will continue to treat more patients. So yes, there may be some change to the length of time people wait for routine surgery, but actually we will continue to treat more and more people. We'll do more operations, and perhaps we'll reduce some of the variation that we've got across the country.
Let's bring in Dr. Hilary, of course, at the front line alongside you as well. Hilary, undoubtedly, there certainly seems to be a lot of elements in this that will work. The cancer targets, as Jane was just saying, will be a real sort of tonic to lots of people in that sort of situation at the moment. But one of the things that we mentioned on the way in, cutting the number of people sent to hospital to see a specialist, getting the patient's GP to phone the consultants for advice. Is that something that's not happening already?
Well, it does happen. As a practising GP, of course, I can speak to my consultant colleagues and get their advice. The problem is that consultants generally trust us to know when patients need to go and see them. We don't need that negotiation beforehand. And what I really fear here is that if we're saying that, yes, we'll have better cancer care services and we'll have to neglect some of those people with hip and knee arthritis, those people might stumble and fall as a result of being immobile. People waiting for cataracts might not see some furniture or a rug on the floor. They might fall, fracture a hip, and then they become accidents and emergencies too. So by robbing Peter to pay Paul, it doesn't always work, and that's my fear.
OK, what about that then?
So I don't think that's necessarily robbing Peter to pay Paul. What we're saying is that, of course, GPs will refer into hospital consultants when they need to, but for many GPs they tell us that what they want is quick advice, and using some of the technology that's available they can actually ask for advice from a GP rather than wasting an appointment.
What about the point that he made, which I think will strike a chord with people, which is if you're waiting for hip operation, other problems might occur that lead you to go to A&E. If you're waiting for a cataract operation, not life-threatening, but you might fall and cause further strain.
And escalates, doesn't it?
Absolutely, and I can certainly understand the concerns that are being raised.
But that's a risk you're prepared to take in a way.
But we're not saying that we are expecting waiting times to increase massively. We are saying we will continue to treat more people, we will do more operations, and we need to reduce some of the variation we've got across the country. So, for example, some places might struggle slightly more than others, but and Simon Stevens yesterday did not say that we were getting rid of the target, for example, around the length of time patients wait for surgery.
There seems to be an admission that you weren't going to hit it, though.
What we've said is that in some cases that some people may have marginal increases in waiting time, but at the same time we will be providing a lot faster and more appropriate care for people that need urgent treatment. And actually that's what patients and people have told us they want.
Hilary, let's just come back to you very briefly before we have to leave this. I mean, what we're hearing from Jane is the optimism is a hugely important part of this, and I'm sure you will condone that as well, and you will say, look, staying optimistic when anybody's feeling ill is an important part of it. But what do you think is going to be the key takeaway for you as a GP and for your patients from what's being suggested this morning?
Yeah, listen, Jane and I are saying the same thing. We're both passionate about the NHS and looking after our patients, and I agree with her with everything she said. The trouble is, what we should be fighting for is better funding. We're trying to achieve something with the same funding that we had last year, next year. And if we're going to make these improvements, it simply can't be done. We're so efficient already in the NHS that it's difficult to see where we're going to make these improvements without more resources and funding. It's all very well talking about more specialist nurses, but we're losing GPs faster than we're actually recruiting them. So unless we address that, the staffing problem, the demoralisation, the huge workload and the stress, we've got an NHS that's still going to be struggling. We need more funding, and I believe the public are right behind the NHS and are willing to provide it with some creative ideas.
Yeah, I mean, that's the problem, isn't it? You're doing your best with not enough money.
So what we've actually had is the result of the extra money that we've gone into social care will actually help us to free up the beds that allow us to treat more people. And the plan does include some significant additional financial contributions that we are making into the service. There's always everybody will always say that people need more money, but we've also got to make sure that we reduce the variation we've got in terms of spend, that we make the best use of the money we've got, that we procure services in the best possible way, and we reduce waste. And we've already done that by reducing agency nurse costs. We now need to do some of that for medical locum costs as well, and we will start to make some improvements into that efficiency as we go through.